Morning's discussion on Psyfeld. Our episode that we'll focus on is the checks. So those of you who were able to view the episode, where would you like to start? What particular behaviors in the checks were interesting to you? Viewer's choice. Start anywhere. Dr. Gelfand students can unmute. Feel free.
I guess one place we could start is Eileen's boyfriend. I kind of noticed that he had a few traits of like a cluster B personality disorder, more like histrionic. He would have like theatrical emotional expressions. He was easily influenced by like the situation, especially with the umbrella scene where he assumed just Jerry had no idea about umbrellas. And he seemed to like rapidly shift emotions in between things. So I don't think he had the full criteria to meet it, but definitely like some of the little points of it.
Right. Good point. So from a clinician's perspective, if we identify behavior and or personality traits as potentially impairing function, we begin to formulate what might be going on, whether there's a true diagnostic label or not. And I heard that there was a dramatic spin on what he was doing. Did you feel as though he required or needed to be the center of attention? Anyone?
Yeah, I think I'd say so. He tried to play it off as though he didn't, but like you were saying last time, when you have a really strong reaction to a patient when you walk into a room, the immediate feeling is just intense dislike of this character.
So you didn't like him, huh? Yeah.
No.
You actually cut to the chase in terms of a very common question in didactics. Did you like him? So there might be something going on here. And I also heard there was a rapid shift in emotion. This is called dissociation. Now, dissociation has a few meanings in psychiatry, one of which has to do with it being labeled a defense mechanism. So it's a subconscious process, specifically of the ego, that alleviates anxiety that's caused by what an individual wants to do, their id, that's the pleasure principle, versus what they believe they're allowed to do. That's the superego governed by the reality principle. This conflict will always cause anxiety, and anxiety will always be alleviated by the ego if there is ego strength. And the actual mechanism by way the anxiety is mediated or reduced to hopefully sub-threshold levels are through one of multiple defenses or defense mechanisms, and dissociation is one of them. Right? And this is a little bit different than dissociation as it is printed in the DSM, defining disorders like dissociative amnesia, which of course is going to be part of our daily didactic today. In this case, the definition of dissociation as a defense mechanism is that there is a rapid yet temporary change in affect, shifting from an unpleasant state. And one example could be when the individual is not the center of attention to a more pleasurable one, which of course, as one example, would be when they do become the center of attention. So it's the over-the-top type of reaction and dramatic type of personality, style, or trait that then the viewer might observe. And if we think that's what's going on here, that is certainly suggestive of the histrionic personality disorder. Individuals with this condition, like Elaine's boyfriend, have low self-esteem, and as a result, do not have what is referred to as an internal locus of control. Right? That's Bandura in terms of the theorist, and that's social learning theory. internal locus of control. Instead, the alternative is to have an external locus. That is, how we evaluate ourselves is primarily the result of the way others view us and the feedback we get from others. And that's not to say that's not important, but when that becomes the only way or the primary way in which the individual believes in or thinks of themselves, that can become problematic. There are individuals who, when they post something, do not get 100 likes within the first X minutes, believe that they are bad, right? And that's a problem. And if that problem is part of a larger constellation of symptoms, perhaps even a list of DSM criteria, one thought is that this might be the histrionic personality disorder, that individuals' driving need to be the center of attention because they have their self-esteem infused from the external source that is an external locus of control. So that would be in our differential with regard to Elaine's boyfriend. Now, has anyone seen anything with regard to this character that might be in addition to this, or maybe contrary to this idea of the histrionic personality?
He's very brand obsessed. That there's this one designer, I think Farbman or something, that he takes a lot of.
We lost your volume in the last part, but I think I got your point. Anybody have any thoughts about what's behind that with regard to his being quote unquote brand obsessed? I mean, if this individual presented to you with asking for help, and the help may not be, Doc, I think I'm histrionic, or Doc, I'm overly dramatic these days. It may be the sequelae of that. That is, individuals with this condition may actually present with a chief complaint of anxiety, or maybe even depression or dysphoria. And now he is in your office, and you notice that he becomes focused on particular brands. In the back of your mind, what might be the root of this, or at the root of this? What do you think's going on? How would you react to that if you're part of that conversation, even outside of an office setting, even outside of a psychotherapy session, and you're part of a routine conversation with him? What do you think might be going on?
If he's brand obsessed, I wouldn't think of a specific diagnosis, but I would just think more of the fact that he feels like he has to tie himself to something probably like bigger, as a form of self-importance or as a form of identity. You know, we see the people who, on like an exaggerated level, only wear like Adidas, only wear Nike, like only wear Gucci, and like that's how they identify who they are, because maybe they may lack the introspection to define who they are. So it's easier to tie yourself to a bigger brand that already has a name or values, or, you know, a certain principle or vibe about it. So if you tie yourself to that, you have to do less explaining for yourself.
That might be what's going on here. So again, just to paraphrase, when you tie yourself to a particular brand, you might do so that when individuals think of you, they think of the brand, and you could almost adopt the popularity of that brand, and therefore yourself be that popular figure. Again, so it's a way to adopt an identity. That could certainly be something that's going on here. And you know, the fact, and I'll take it even one step further, the fact that he name drops the way that he does with regard to that particular brand might be a way to exert his power in introducing himself. I am important, right? I only would buy this. Again, almost his name becoming synonymous with the name brand. That could definitely be what's going on here. Now, or this could be something that is totally in the context of quote unquote normal conversation. Again, if it's clinically significant, we want to investigate it. And certainly we'd want to see if this were pervasive, which is, of course, what we always want to do when we're investigating a personality disorder. That is, do we see this kind of overflow into other settings for him, other social situations, other than these interpersonal communications? And if the answer is yes, again, it might be who he is. The common variable will be him. And therefore, this might be more consistent with a personality disorder. So, yeah, he does name drop. And, talking about Farber may not be all that different than having met someone who's important and name dropping them, almost as if, I had a conference that was co-presented with so-and-so. Again, if that's just true in an isolated incident, so be it. But if it becomes repetitive, and if the repetition itself becomes clinically significant, it's much more, and it's outside the range of what would be referred to as "quote unquote" normal behavior. Any other characters in this episode? We're discussing the checks.
I was actually thinking about George as well. He seems, maybe there are some narcissistic traits within him, but he's very egocentric. In the last episode, he was like hung up on getting this girl, and in this episode we're seeing him being offended that the cult didn't reach out to him. And he made a side comment about the female Japanese executive. You think she's into me? So he seems very self-centered, and that's just becoming more and more apparent.
Yeah, and that is something that is very pervasive. That is the egocentrism of George Costanza. Again, very limited self-esteem. What Kohut would have referred to, or did refer to, as I believe it was normal infantile narcissism, aka self-esteem. For an individual to act like this when they're 3 or 4 is completely within normal development. Children understand that the world revolves around them. And a lot of the things that happen, they will either take credit for or blame for. And we see this in child psychiatry, certainly, with regard to the death of a loved one. And they could believe that they had something to do with that death, or mom or dad leaving and separating. It was my fault. That's a fairly straightforward, normal process when age appropriate. At some point, the child does evolve and sheds that egocentrism for empathy, and they begin to experience the world through others' perspectives, adopting that. Of course, if that doesn't happen, then they continue on that course, that same rail, and further solidify or crystallize their egocentrism. And that's what happens with George Costanza. We don't have the prequel to this, but there was something that happened, and it probably wasn't just an isolated event. It wasn't necessarily a single trauma. It was probably repetitive and throughout his childhood, that he was never able to gain the perspective of empathy. He's just not an empathetic character. And therefore, another way of saying that, he's a very egocentric character. Egocentrism itself can be the gateway, or a gateway, to future mental illness. And the personality disorders certainly are in that differential, and the cluster B personalities in particular. So that again is a background to George Costanza, and we see this again. Of course, this becomes even more heightened when there's interpersonal relationships, even intimate relationships with George. That's when we see this egocentrism at its greatest intensity. But he's put off that the cult did not want to recruit him. Other thoughts about George or any other characters you'd like to discuss this morning in Psyfeld?
I wanted to talk a little bit more about Jerry and his behavior with the checks, in reference to the title of the show. So it almost seemed obsessive, his attitude towards the checks, where he was getting hundreds of checks on order of cents, and he was literally hurting himself, where he was getting like carpal tunnel just from signing so many checks. And while I didn't necessarily fit like the diagnosis of obsessive compulsive personality disorder, I definitely thought he was showing traits of it, and it seemed to me to be more egocentric because it was in relation to his aspirations of becoming a movie star in Japan.
So I guess my first question is if we define obsessions as intrusive thoughts, and then therefore define obsessive-compulsive disorder through intrusive thoughts that are clinically significant, would that fit for Jerry in this particular episode?
I think so. I mean, I don't know why else he would feel the need to be signing so many checks, and I think that just knowing that he's getting paid for his persona is what drove him to repeatedly keep signing and signing and signing, where he's injuring himself.
I agree. So from that context, again, Jerry is likely to present to a non-psychiatric clinic with a chief complaint of dystonia, right? And he might see a neurologist, and I think within a routine history and physical, he is likely to disclose the plot of this episode, in that he is signing so many checks. A past medical history, would include whether or not he's had any other types of dystonic reactions or any other dystrophies. I mean, again, it's going to be a neurology appointment, and it's going to be a routine H&P in that neurologist's office. And if Jerry actually discloses or divulges that this has happened to him before, and it is uncovered that when he has these thoughts, they are intrusive and he must act on them, then one of the treatments for his current dystonic reaction would be to evaluate him for obsessive-compulsive disorder, right? I mean, obsessive-compulsive disorder is an anxiety spectrum disorder defined through clinically significant obsessions and or compulsions, right? It's that easy when starting out in terms of formulating the most likely diagnosis. Again, obsessions are intrusive thoughts, compulsions are ritualistic behaviors. And an individual may have both, but they don't necessarily need to, per the DSM, per the American Psychiatric Association. If they have one, they may rule in if it is clinically significant. And if we find that behavior to have been clinically significant, in as much as it resulted in his current dystonic reaction, we may have to address that. But again, it would need to be repetitive. If he just had this thought of how famous he could be, and we see the end result, that's one thing. But if we see evidence in a past history that this is something that's happened before and has happened before reaching clinical significance, we may be onto something here. So that's something to consider. Of course, the dystonic reaction cannot be due to an underlying medical condition. In this case, that would include, of course, a neurological condition. So it's a good thing that he presented to a neurologist, not in the episode itself, but in our conversation. And it can't be due to the direct physiologic effects of a substance. From our perspective, again, in taking a history, what substances might we want to inquire about with regard to Jerry Seinfeld, the character presenting with dystonia? So, drugs that could induce dystonia. I mean, we're going to have to ask, right? I think the open-ended question would include, have you started any new medication or drugs, recreationally or otherwise? And of course, the class of medication, especially as a psychiatrist, that we would definitely need to inquire about are the antipsychotic meds. Antipsychotic medications can induce dystonia. In this case, dystonic reactions could be either focal, localized to a particular muscle or muscle group, or it can be generalized, multiple muscle groups. When addressing dystonic reactions that are generalized, of course, we want to optimize, if not discontinue the offending agent. Right? So switch, in our case, the antipsychotic for an alternative that has lower or less risk of inducing dystonia. However, in the acute management, we often give an anticholinergic medication. That could be something over the counter like Benadryl. There are others, obviously, either PO or IV through the vein that can also be given. One of the most popular is benztropine, which is cogentin. For focal dystonic reactions and for medical students out there who are studying for their shelf exam, be very careful, because while for general dystonia, we know that anticholinergics are the first line treatments along with benzodiazepines. Anticholinergics and benzodiazepines are second line treatment for focal dystonic reactions. On your shelf exam, skip over benzodiazepine for choice A and look further, choice B, C, or D. Botox is the single best answer. And it's not something that is Botox injections. They're not something that we would anticipate seeing on a psych shelf, but that is the single best answer for focal dystonic reactions. The other thing I want to mention about dystonic reactions is that they are hyperacute, meaning they are usually the first EPS, extrapyramidal side effect, that the clinician sees, the patient experiences. They usually happen between 4 hours and 4 days of either starting a new medication, starting a new antipsychotic, or adjustment in the dose. 4 hours to 4 days. And the one dystonic reaction, especially in the hospital, that we have to always be concerned about is laryngospasm. That could certainly compromise the airway. So if you are using neuroleptics and you're concerned about dystonic reactions, neurochecks every 2 hours is something to strongly consider to avoid laryngospasm that would compromise the airway and it may even result in need to intubate. Any other thoughts about Jerry? Anybody else want to tell me the other EPS examples, since we can go off on this tangent a little bit and talk about side effects, common side effects of the antipsychotic medications?
Akathisia.
Good. Akathisia is the most common EPS, and where acute dystonic reactions occur 4 hours to 4 days. Akathisia, we think along the lines of 4 days to 4 weeks. Akathisia is the neurological term for motor restlessness. Individuals may feel the need to pace. They may feel the need to consistently shift their weight when they're trying to stand still. So please inquire with regard to patient care. Specific examples. Do you feel fidgety? Do you feel that you always have to shift your weight when you're standing? To uncover potential akathisia. Again, it's the most common, and it's the one we usually see second after acute dystonic reactions with regard to the timeline, right? 4 days to 4 weeks. Treatment of choice, other than optimizing, if not discontinuing, the dose of the offending agent.
I believe you can use benzodiazepines, beta blockers, or benztropine.
That's right. I think that the benztropine and the benztropine and the benzos would be second line agents, beta blocker first. If the individual has second degree or third degree heart block or asthma, go with the benzodiazepine or benztropine. Okay, second line agents. Other forms of EPS.
Would you have to be worried about using beta blockers too if the patient has diabetes?
So the concern about beta blockers and diabetes is that they may mask the symptoms of hypoglycemia. So if your patient's diabetes is not well controlled and they're having episodes of hypoglycemia because perhaps you're still, the primary team or their endocrinologist is still trying to optimize their diabetic regimen, which probably includes insulin, then until that gets regulated, yes, it may be a good idea to avoid the beta blocker, because when that blood sugar actually gets to 40 or even 30, the signs of hypoglycemia, certainly when observed, can be life-saving. And if they're masked by the beta blocker, that could have certainly significant morbidity and perhaps even mortality. So in such cases, yeah, go with a second-line agent. And then once their diabetic regimen is optimized, you can reconsider starting the beta blocker. Again, the beta blocker may actually simply mask the diaphoresis and the shakes that would indicate low blood sugar or hypoglycemia. Other forms of EPS.
Parkinsonism.
Yeah, Parkinsonism. Parkinsonism is clinically indistinguishable from Parkinson's disease. Of course, in Parkinson's disease, we have dopamine that is at too low a level due to the soma, due to the tracts degenerating in the substantia nigra, right? So it's a CNS disorder. On the other hand, when there's nothing wrong with those dopaminergic tracts, but what is wrong is that the CNS dopamine is lowered through a pharmacologic agent like an antipsychotic, well, the individual can look like they have Parkinson's disease. And when it's uncovered that it is medication induced, it is referred to as a medication or neuroleptic induced Parkinsonism. So all the signs and symptoms that would indicate Parkinson's disease is consistent with neuroleptic induced Parkinsonism, including the shuffling gait, the masked faces, the difficulty initiating movement, and even the Parkinsonian tremor, which is a pill rolling tremor. There's a second type of tremor that can also be observed that is called postural tremor, which is tremor against gravity, meaning that as a bedside maneuver, individuals are asked to extend their arms and spread their fingers, and the clinician will then observe a tremor. In both cases, postural tremor and Parkinsonism, and therefore the tremor that might be part of neuroleptic-induced Parkinsonism, we think that between 4 months and 4 years with regard to the onset of these types of side effects, these specific EPS. So again, 4 hours to 4 days, 4 days to 4 weeks, I'm sorry, 4 weeks to 4 months. I actually misspoke. 4 weeks to 4 months, those two effects. And then 4 months to 4 years, you're now focused on the late or tardive effects, specifically Tardive Dyskinesia, which is an involuntary movement disorder. Okay, so involuntary movements caused by the chronic effects. These are late findings, AKA tardive findings, referred to as Tardive Dyskinesia, involuntary movements as a late side effect of the neuroleptics. Unlike the side effects of the EPS we initially discussed, again, in order, that would include dystonia, akathisia, tremor, and Parkinsonism, all due to lowering the dopamine at the level of the nigrostriatal tract. Tardive dyskinesia is the opposite, because as your brain compensates for all this dopamine lowering, it will upregulate receptors. And it's that upregulation that occurs late in the course, in 4 months to 4 years, that results in the involuntary movements. And if the clinician is not aware of this, and if the prescriber misses this, it could become irreversible. So you need to stop the offending agent immediately upon discovery of early onset TD, tardive dyskinesia. Again, it's a compensatory effect, an upregulation. And if you're evaluating a patient, let's say on consult, where you weren't the prescriber and you notice some, let's say, perioral movements that appear to be involuntary, one of the questions you can ask the individual is if their medication has been increased recently and what happened if and when it was increased, because increasing the medication will actually temporarily decrease tardive dyskinesia. Unfortunately, those involuntary movements will reoccur. It's inevitable, usually resulting in clinical practice of further increasing the medication for, again, temporary relief. And if you, again, ever observe this, verifying the recent history of dosage increases alleviating the symptoms would certainly then support tardive dyskinesia immediately. Discontinue the medication. And if you're asked on a shelf exam or on a standardized exam, what single neuroleptic the clinician should consider switching to, it's clozapine. Switching over to clozapine is the single best answer. It is the medication that has by far the least potential to either induce or continue the tardive dyskinesia. All right, we're going to end it here. We're right at the bottom of the hour. I will see everybody in a little bit.